Good evening. I'm Beth Rosemurgy. I am a family physician. I'm the department chair at University of Missouri, Kansas City Family Medicine Department. I'm also the vice chair of the MAFP and the co-chair of Education Commission. So we're excited to have Dr. Rebecca Aguayo here to present the 2023 CDC update, HIV positive birthing persons and provision of human milk. Personally, Dr. Aguayo is a colleague and one of the faculty in my department, so I'm thrilled to have her here and showcase her unique perspective. So tonight's presentation will be delivered live and the presenter will be available for questions following her talk. Feel free to drop questions in the chat window as they come up during the presentation, and we'll monitor the questions and moderate them at the end. And then you're also welcome to speak up and ask direct questions at the end of the presentation. And I'm sure Dr. Aguayo actually wouldn't mind you doing that during the presentation. Participation in tonight's presentation qualifies for up to 1 CME credit. The session's recorded and uploaded to the MAFP YouTube channel for future viewing and reference. CME is only available for live attendees. Please complete the very short survey from the link that Bill sent in today's reminder email, and that will also be dropped in the chat at the end of the presentation. And information entered there is used to report your CME to the AAFP. So this is the 8th of 10 sessions that the MAFP is presenting this year. And we have 2 sessions coming up: value-based care for family physicians on September 19th, and primary care dermatology in skin of color on October 17th. So if you really like live in-person CME, like I do, we look forward to seeing you at the annual fall conference in November. This year, it's November 7th through the 9th. We start off with an optional OMT for all physicians, interactive procedures workshop on Thursday, November 7th. And the conference is being held at the 4-diamond rated Intercontinental on the Plaza in Kansas City. And registration is now open, and we'd love to see you in Kansas City. So without further ado, please welcome Dr. Aguayo.
Hi, yes, I'm Rebecca Aguayo. I heard that I'm out in Kansas City. I want to say thanks for everyone who's actually tuning into this talk both today and in the future on YouTube, because I do recognize that the title of the talk is pretty darn specific. And so I can see a lot of people thinking, maybe like, how does this apply to some of our general practice? And so I appreciate you all being here. Personally, my practice is pretty heavy in terms of maternal care. I did do the surgical OB fellowship out in Kansas City at UMKC. And so I do about 1/3 of my time as laborist shifts, 1/3 of my time in our maternal care, prenatal and postpartum care clinic, and then 1/3 of my time in my primary care clinic. And so for me personally, this talk kind of fits with the populations to some degree that I'm seeing. I'm seeing a lot more moms, babies, pregnant patients, dyads that I'm counseling on this talk, although it's not incredibly frequent that we have HIV positive birthing persons. So without further ado, I will introduce the talk, as you said, HIV and human milk. And my disclosures here that I have no financial disclosures involved in any of these topics. However, I do want to disclose that I'm neither an expert in infectious disease, and I'm not managing these dyads or pregnant patients at any sort of a level of high volume. However, this topic came to me because it was such a paradigm shift when I first learned about the changes in the recommendations in regards to HIV and breastfeeding, because I was recently coming out of training, and under no circumstances was an HIV positive person supposed to breastfeed in the United States, which was the way that I had always been taught. So you'll hear some stories throughout the slides about kind of foot and mouth experiences and learning about these changes. So I wanted to make them known to others so that hopefully we can try to save others from having similar experiences with such a big change that happened last year. A brief overview on terminology. I will generally, as best I can, try to use like gender neutral terminology as far as breastfeeding or chest feeding, body feeding, human milk as opposed to breast milk to the best of my ability, but my vernacular is more consistent with consistently using breastfeeding and breast milk. So I will do the best that I can, but in general, If you see HM or EHM, it's going to refer to human milk or express breast milk for gender neutral terminology. This is stating exactly that. Other terminology and abbreviations that I will use throughout these slides to help kind of speed things along and shorten the amount of information is including the VL, viral load, ART for antiretroviral therapy, ARV for antiretrovirals, MTCT specifically for maternal to child transmission, and then drug abbreviations will be referenced because my goal with this talk is not specifically to go through the specific pharmaceuticals that we should be using to manage either the mother, the birthing person, or the infant, but more so kind of the patterns of how to educate, counsel, and take care of these patients postpartum. My agenda today, I would like to just spend the next hour with this group considering the CDC's recent recommendations that regarding the changes made for persons who are HIV positive, giving birth, and who desire to provide their own human milk to their infant. And then consider the implications of these changes as a field who provides care for pregnant and chest feeding persons and infants, noting that we see both moms and babies in our practices, or birthing persons and babies in our practices. The patient case that prompted this particular lecture for me was a mother that I had taken care of last year in March of 2023. So by dating, this was about 2 months after the CDC had changed their guidelines and I was not yet up to speed. So March of 2023, I have a G3P2 who presents in my clinic for a return OB visit. Her first pregnancy, she was in her second pregnancy. Her first pregnancy, she had both pregnancies were delivered in Africa. And this G3 pregnancy was the first pregnancy that was cared for here in the United States. So in her first pregnancy, she had a postpartum hemorrhage that required several units of blood transfusion. She was HIV negative during that pregnancy, and then found to be HIV positive in her G2 pregnancy. So they had suspected this secondary to transfusion, and she had breastfed both her G1 and her G2 infants. And she presented to my clinic fairly early in her pregnancy. I want to say we were in the first or early second trimester when we were initiating these discussions. But she relayed her desire to breastfeed. And then maybe by the time I was coming through, it was later in the pregnancy. I don't quite remember that, but I'm sorry. That was because when I initially presented this lecture, she was due in a month. So she and I first initiated the conversations early in her pregnancy. So she is the index case that prompted me to learn more about this topic. In her particular case, our ID team had this patient on Tivicay and Truvada, which they were considering as a common considered pregnancy safe regimen. She was transitioned onto this regimen upon finding out that she was pregnant, and this patient had a sustained undetectable viral load for the duration of the pregnancy to date. And we'll talk about the terminology and kind of what that means and how to clarify what sustained undetectable viral load is in future slides. I had alluded to this a little bit earlier, but again, the previous recommendations in the United States were that under no circumstances is provision of human milk to the infant if provided from the HIV positive person recommended. So quite in stark contrast to the changes that came in 2023. International recommendations, however, differ. So the international recommendations for each country are based on resource dependence. So I did include a little bit of information here about Missouri specifically, because this had surprised me last year when I was preparing this, but about 17% of the US is on unregulated well water. And if you actually look into the formula preparation information, these homes that are serviced by well water are actually not recommended to use their own water. Upon reading this, did not realize how many of those communities are so close to my local hospital, and the number of conversations I had previously about proper formula preparation as far as purchasing water. Also noting that that's a difficult ask for families who might be financially limited on their ability to purchase purified water to prepare their formula. But this was something that I realized that water also in our locales might be not considered useful for preparation for formula. The international standpoint it does depend on their access to reliable formula and or reliable healthy water sources. So each country factors in information regarding the risks of malnutrition, dehydration, and infection that are related to the numbers of childhood deaths or infant deaths. And if those risks seem to outweigh by quantitative analysis the risk of HIV acquisition in the infant, and we'll talk about the percentages of HIV acquisition in infant in some of these countries later. If those risks outweigh the benefit, then they will recommend no formula use and will recommend breastfeeding for those countries. So this is how I was taught this in medical school. And I thought, wow, like this makes a lot of sense. Public health, and infection control, infection prevention, so to me, I thought that I was having a fairly well-educated with this patient. So educated conversation with this patient. And she looked me dead in the eye. It was my first time meeting her. So we didn't really have a rapport built just yet, but she looked me dead in the eye and said, so you mean to tell me that my doctor never asked me if I was okay with putting my child at risk of getting HIV because they thought that I had bad water? You mean to tell me that I could have been making formula and making it we had access to good water? You mean to tell me that I could have put my prior children at zero risk by by doing formula milk, but I was told to breastfeed simply because I lived in Africa, simply because I lived in this country where other people might not have access to clean water. I had access to clean water. So of course I'm on the spot where I'm like, oh shoot, I'm sorry, your doctor didn't have this conversation with you. I'm like, what do you say in that situation? She and I kind of teased it out and she just starts chuckling and she's like, girl, don't worry about it. I'm still going to breastfeed this baby. I would have breastfed those two also. I'm just giving you trouble. So I throw this slide in there for my part on humility of where I thought I was kind of sharing with her why we have these differences between Africa's recommendations, where she was located, and the United States recommendations. And she totally turned the tables on me. So it was a pretty good experience, if I do have to say so myself. So I would think about the manner in which you discuss that if you ever find yourself in a similar conversation with a patient. So kind of turning the attention to clarifying the population that we're specifically talking about, because there are several nuances to who in particular this presentation is actually referring to. So trying to clarify the population of interest, I have highlighted here kind of the bold information for what is particular about honing in on the population that we're discussing. We are specifically discussing birthing persons who are HIV positive with sustained viral suppression, adhering to effective, highly active antiretroviral therapy, and providing their own human milk while continuing antiretroviral therapy, and ongoing personal viral load testing for the mother, and ongoing infant HIV screening for the baby. That is 8 criteria that we are trying to have met in order to say, yes, within our clinical judgment, we support and will provide continuing guidance on breastfeeding and breastfeeding safely. So that is a lot of criteria to meet. But there's a lot of hoops to jump through to make sure that both mom and baby are cared for, mom is educated, or the birthing person is educated in this process, and in a way that allows us to do our best care for both mom and kiddo. So in prenatal counseling, one of the things to include is the benefits of breast milk as we know them, including that infants have a known lower risk of asthma, infectious gastroenteritis, otitis media, obesity, type 1 diabetes, SIDS, NEC. There are some others that you can find and put on this list too. For the birthing parent and for the patient that I was taking care of, she actually cited all of these. Like, she knew this information and she was like, I would like to take my risk of lower breast cancer, endometrial cancer. I was very impressed with her knowledge here. For the birthing parent, lower risk of hypertension, type 2 diabetes, breast, endometrial, and ovarian cancers have been shown with breastfeeding and length of breastfeeding. And then other things to consider are the bidirectional benefits that we don't quantify so well. So this includes parent-infant bonding and then financial options as far as reducing cost and for purchasing formula and potentially purchasing clean water. Other benefits to consider, I can't find any studies on this per se, but I did, as I was preparing this presentation, I did see in several forums discussions that were happening about amongst birthing persons who were HIV positive, and questions that they were asking, like questions that they were like, I would like to ask my doctor this, but I'm too embarrassed, etc. One of the recurring themes that I saw pop up that I was curious about was that if a person with HIV is providing their own human milk, does that improve their contact and connection with their infant? So there are parents who are posting on these forums saying like that they've never, like they're not hugging, they're not kissing their children because they're so concerned about transmitting HIV that they're not providing that like close connection and contact. So if you start your child's life by breastfeeding and having that level of closeness, like what kind of social and emotional benefits does that like have on the sustained lifetime for this child? Like we probably won't ever know. But if our parents are having these questions and they're too afraid to ask us, these kind of emotional connections can be something that they're missing with their children. And additionally, if a birthing person is providing their own human milk, does this increase maternal or birthing person's adherence to antiretroviral therapy? Are you more likely to stay on your antiretrovirals in your postpartum period simply because you know that there's a risk to your baby? And does that potentially improve maternal outcomes, postpartum outcomes for women who are remaining on their antiretroviral therapy in the postpartum period? More for their infant, because a lot of times we'll do more for our kids than we'll do for ourselves. Again, I haven't found any studies on these. These are just kind of questions that popped up that in the process as I was thinking through this. Going through, continuing, this is still in that prenatal counseling section. So going through the feeding options is also important because there are alternatives. As my patient so kindly pointed out, birthing persons affected by HIV, infant feeding options, and kind of namely, there are 3 different groups, but the goal here is to sit down and have a conversation that is patient-centered, evidence-based, and that leads to something that's shared decision-making. It doesn't have to be solved in a day. This is something that can be solved or worked on throughout the prenatal care course. Or ideally in primary care, this is something we can be talking about before the patient ever becomes pregnant. The options for eliminating or reducing risk of HIV transmission include replacement feeding. So this is either with properly prepared formula, which has 0 risk, pasteurized human donor milk, which has 0 risk. So these are our 2 0 risk options. Or if you're providing human milk and achieving and maintaining viral suppression, the risk of HIV transmission to the infant is less than 1%, but not 0. So in your 3 groups of options, you have 2 that have 0 risk of HIV transmission and 1 that has a less than 1% risk on average. From here in the prenatal counseling course, what is the role of the physician before the decision is made? We've alluded to some of these on the prior slides, but to be more clear, the counseling should include details about the infant's antiretroviral prophylaxis options and plan, maternal adherence to antiretroviral therapies, discussion about the maternal viral load suppression and the viral load testing schedule because it is frequent, and then infant screening schedules. That is also frequent. So these are things that can burden the family, but allow us to help keep the mother apprised of her infant status and try to help her keep apprised to her own viral load status to try to reduce the risk of her transmitting HIV to her infant. All 4 of these components are things that need to be discussed, again, ideally over the course of the pregnancy in order to help her understand her wishes and desires for moving forward. The role of the physician after the decision is made changes a little bit. From here, the goal would be to support and evaluate if there's any sort of barriers to her formula feeding considerations, if there's a reason that she feels compelled to choose human milk feeding, And then once we know know those barriers, if she is sound in her decision, then our goal is to support and just continue to follow her and support her through the process of choosing human milk. I feel like it's unfortunate that they had to go in and state this directly, but the CDC puts on multiple pages that engaging child protective services or similar agencies is inappropriate. I included that as well because I assume that this came because this is happening in some places where they're engaging child protective services because of the parent's decision to provide breast milk or human milk. And then if human milk is chosen, we need to continue to support exclusive human milk use up to 6 months of age. They don't recommend planned mixed feeding unless it's medically indicated. Planned mixed feeding would be your mothers that are planning on providing human milk and formula simultaneously. The medical recommendation from our standpoint should be exclusive human milk up to 6 months of age because they've demonstrated an increased risk of transmission if you are doing planned combined feedings. The next series of slides will go into the various topics that we were discussing on the one slide, the 4 groups of things to be discussing with your mothers prior to, as far as your education, initial education and ongoing education. So in discussion, basics of the risk of transmission. The risk of transmission needs to be relayed as if you are on antiretroviral therapy with a sustained undetectable HIV load during pregnancy, the rate is less than 1%, but not 0, as you've heard previously. To compare the risk, mothers in other countries who are not confirmed to have sustained viral loads, and keeping in mind that many other countries only have mothers on antiretroviral therapy for about 6 weeks postpartum. Some of the studies keep them on antiretrovirals until about 6 months postpartum, but not continuously. And so the infants who are exposed to mothers who may subsequently in the postpartum period not have a sustained viral load that is suppressed, there's a 15 to 20% seroconversion rate within the first 2 years. And this is if the infant is also not on antiretroviral prophylaxis, which again, many other countries use a limited time frame for antiretroviral prophylaxis for the infant, about 6 weeks or so. The discussion will go into how things are different in the United States as far as both maternal sustained antiretroviral therapy and infant sustained prophylaxis as an option as well. Defining sustained. So the definition at basic definition is minimum throughout the 3rd trimester and at delivery. So if you have a patient who arrives in the clinic in 1st or 2nd trimester with a new diagnosis of HIV, as long as we can progress throughout the pregnancy into a place where it's considered sustained in the 3rd trimester, that person would be considered a candidate for providing expressed or direct human milk after delivery. And or that person would need to, if not sustained in the 3rd trimester, would be someone that would need to be considered pumping for and discarding or for the first several weeks to months after, before reaching more of a sustained level where they could provide human milk later. Additionally, sustained means they need to continue to be sustained undetectable viral load at delivery. So those labs that we order immediately upon admission become important. The parent should be educated on various topics regarding the safety of antiretroviral therapy for the mother and antiretroviral therapy for the mother, the effects on the neonate. As well as the effects of antiretroviral prophylaxis for the neonate. So there's a lot of kind of bidirectional pharmaceutical things that can happen in the setting of infants that are getting exposed to antiretrovirals by breast milk, parents who are breastfeeding on antiretrovirals and so forth, or providing human milk on antiretrovirals. So a couple things to think about here. The first step that I'm going to take you through is specifically the safety of the parent antiretroviral therapy for the neonates. And some of the information here, there's more details you can read about each individual drug to a much greater degree on some of the resources that are available on the CDC. But things that stood out to me include that there's variable levels of each of the drugs that we can use for antiretroviral therapy. in human milk. It depends on the antiretroviral regimen, which makes sense. However, they find that most of them actually are lower than parental plasma volumes. There are two exceptions that I listed below, is zidovudine and I think it's tenofovir. Both of these are higher in human milk than in parental blood. And interestingly enough, they've had studies that have shown lower incidence of viral transmission via human milk when these medications are found to be in higher level in the breast milk. The kind of the same topic, this is still safety of parent antiretroviral therapy for neonates. Despite having some detectable drugs in human milk, few studies have demonstrated a detectable drug in infant blood samples. So again, that tenofovir is still detectable. Serious adverse events to the neonate were uncommon. However, something to consider is that if the infant is not on antiretroviral prophylaxis, then they are exposed to subtherapeutic levels of transmitted antiretroviral therapy. And this has been shown in some studies to put infants at risk of antiretroviral drug resistance if they do acquire HIV. For me personally, this I feel like is a pretty strong argument for sustained antiretroviral prophylaxis for the neonate. But we'll see as we come to later slides that discussion is on expert opinion. There's not a strong recommendation one way or another, but this point stands out for me that I would not want an infant to develop a drug-resistant HIV infection if I could prevent it. The same topic, we're still talking about antiretroviral therapy, safety for neonates. The information resources that I looked for in terms of trying to find out what the effects of these medications could be through human milk on infants, the best resource that I have found is on the CDC website. The Appendix B, it goes through every medication in detail, and it's the most comprehensive resource that I was able to find. Two other resources that I've commonly used for understanding the risks of medications through breast milk have been Infant Risk and LactMed. Infant Risk doesn't have much updated information. I anticipate maybe in the next couple years or decade or so that they will start to add information because they are a United States-based entity out of Texas. And so they've not needed to update this because we were not generally providing human milk to infants from HIV positive birthing persons before. And then LactMed, they do include a little bit of information because they are an NIH-based group, so they do use a little bit more of the WHO information and some of the research studies out of Africa to provide information there, but I did not find it superior to Appendix B from the CDC. I previously mentioned the serious adverse events were low. Things to know about this is that there are a lot of studies that provide short-term adverse event data. So things like rashes, lower platelet counts, anemia, and things like that in the short term. But there are not a lot of studies that look at the long-term data effects of antiretroviral prophylaxis for neonates in the long run. So hopefully that's something that's an area that'll be better studied in the future. And again, I should have clarified in more detail. This is referring to the infant being on antiretroviral prophylaxis, not the mother being on antiretroviral therapies transmitted via breast milk. So the infant's medication themselves, there's less data for long-term effects. There are, this one did kind of cut off. So there's kind of three common therapies that are used: zidovudine, tenofovir, and then abacavir is the one that's showing up on the bottom that you can't quite read as well. Zidovudine is common side effect is that hematologic mild anemia that I'd referenced before and resolves by 12 weeks. Tenofovir is the additive hematologic anemia neutropenia risk is like the most common complication. And then it's additive with zidovudine. And so you can see out of one Brazilian study, they showed a much higher incidence of anemia than the neutropenia. And I am forgetting the abacavir reactions that were listed there, so I apologize for that. Still on antiretroviral prophylaxis safety for neonates, nevirapine has been shown to have two major adverse event risks, including Stevens-Johnson syndrome and then symptomatic hepatitis and at times fulminant hepatitis for infants. And then there's a condition called severe systemic hypersensitivity syndrome that can develop, but that is not as common as the other two. So that's, for us, I feel like unless you're managing this infants antiretroviral prophylaxis plan, it'd be a little bit challenging to educate on what medication they'd be on specifically. So that is something that would have to be done hand in hand with either PEDS ID, or if you are managing this, making a decision about what prophylaxis plan the infant would be on to better educate the parent about risks in that regard. And risks of ongoing therapy beyond that 6-week postpartum, 6 weeks of life. As far as safety, as far as antiretroviral therapy for the parent, the birthing parent who is providing human milk, there's only been one medication adverse risk with tenofovir that showed associated bone loss for the birthing person. So concern for a higher rate of osteopenia, osteoporosis later, but they have not been able to demonstrate or prove that. So that's still fairly early in its recognition. Important things to discuss. The next part that I'm going to take this through is going through transmission studies. I will share as many details as I can about each of the transmission studies, but understandably these studies are fairly large with an abundant amount of information. So I've tried to summarize them in what I felt like would be most useful to get through. Most of the transmission studies that we have are out of our low and middle resource countries, the countries that we have been noting that they've been permitting or recommending breastfeeding because of lower resources for safe water and reliable formula. The first trial that I want to review is the Mamabana trial out of Botswana. This was a randomized controlled trial of just over 700 maternal infant dyads. And their goal was to try to identify which antiretroviral therapy regimen for the mother resulted in the lowest rate of parent-to-child transmission. And then they additionally included an arm with an antiretroviral prophylaxis for the neonate as well. This study did wean medications at 6 weeks postpartum for the mother. So after 6 weeks, she was no longer on antiretroviral therapy, and the average length of breastfeeding in the study for the 700 dyads was just shy of 6 months. All three arms of this study demonstrated that a maternal to child transmission rate was about 1.1%. So 8 infants out of 709 that did develop HIV. This study is where one of the primary, about 1%, but not zero, comes from. Tanzania also had a randomized controlled trial just shy of 200 patients, and the goal was to assess antiretroviral therapy effects on maternal to child transmission during provision of human milk. So it was a little bit more straightforward and fewer arms in this study. This study had 2 cases of infant transmission, and they demonstrated 0 cases of infant transmission if the mother's viral load was suppressed or undetectable. One of these, the mother or the birthing person came back with a high viral load at 1 month postpartum, and the infant was found to be positive in screening testing right after. And then in the second case, the mother had stopped her antiretroviral therapy shortly after delivery and didn't continue it, and also ended up with a higher viral load later on. The Impact Promise trial, this was a trial in sub-Saharan Africa and India. It was a larger trial, randomized controlled trial of just shy of 2,500 dyads. The goal in this trial was to assess if keeping the infant on nevirapine prophylaxis and the mother on antiretroviral therapy, what the effects were on the maternal to child transmission rates. This trial actually treated both moms, I think moms consistently and stayed on after, but the children were treated through 18 months. that shouldn't have a G there, treated for 18 months or to cessation of breastfeeding, whichever came first. So if they stopped breastfeeding before, they stopped the infant's prophylaxis at that time. In the maternal antiretroviral therapy only, the transmission rates were just shy of 0.6%. When they included the infant on prophylaxis alone, then it was, or separate, in addition, it was also about 0.6. So they were comparable rates, and again, less than 1%, but not 0. So the information to take away from this about transmission studies is that we have limited resource out of limited information out of high resource settings. There is limited information on chronically suppressed viral load patients, but we do see in some of these studies that those who had suppressed viral load, the transmission rate was, in some of the studies, 0. And then studies often included women who started on antiretroviral therapy in the 2nd and 3rd trimester. So a lot of our mothers, birthing persons here in the United States come into pregnancy on with a sustained viral load and are on therapies. As they come in many of these studies, the healthcare systems are set up to not start these women or continue them on antiretroviral therapy. I've already demonstrated generally they're discontinuing between 6 weeks postpartum and 6 months postpartum, already spoken about. In the United States, we keep patients on antiretroviral therapy consistently. So there's a little bit of a different setup there, in that our kiddos here hopefully will have mothers who come in with sustained low viral loads. And then studies in locations differ a lot with infant antiretroviral prophylaxis. The majority don't continue infants on antiretroviral prophylaxis for more than 6 months. The studies we do have out of higher resource settings include 1 out of Toronto, 2 out of the United States, and then 1 out of Germany, 1 out of Italy. And you can see the N in these studies are very small. So nothing that's in the hundreds, definitely not in the thousands like we see out of our African studies and our Indian studies. The good news about the small studies that we do have in our higher resource settings is that they've demonstrated so far 0 cases of transmission. Delivery planning. So changing the course a little bit to be talking about birthday party planning with your patient. Things that I experienced as we were planning for the delivery for the patient I was taking care of last year is that we recognized that team education might be needed. Our OBGYNs were not aware of the CDC changes, and so this came as a surprise when we began having these discussions with their service. PEDS was not aware of these changes as well, but some of the pediatricians locally did come to this talk when I had put it on in the fall last year, and we engaged in some discussion after to try to better plan for the birth of this baby. Social work. I can think of some resources as far as connecting patients may need to be informed, but hopefully would otherwise be supportive and responsive to things that we need. Lactation, our lactation nurses locally had not heard about the CDC change, but were very excited to hear about it and immediately started learning more to try to be prepared for this dyad. And then nurses, nurse education on labor and delivery for providing support and continuing education immediately after delivery as they are trying to get the dyads set up with successful breastfeeding. There are some hospitals across the country who are requiring a signed waiver of risk acknowledgement, and then there are others that are saying that's stigmatizing and are not requiring a signed waiver of risk acknowledgement. It seems like our PEDS department was wanting to do that signed waiver of risk acknowledgement, so that is currently the method that we are using at this time. And then other things to consider in delivery planning, we start talking about birth control planning and options, and to try to determine what the plan will be for after delivery, if there's something you need immediate postpartum or in postpartum visits to follow that we would be addressing. And things to remind ourselves and think about is that there are a lot of medications that affect the enzymatic breakdown of our antiretroviral therapies. And so the last thing that I want anyone to leave this talk feeling, positive about supporting a mother-infant dyad and then putting the mother on a medication that causes her antiretrovirals to be more ineffective, and then she comes back at that 1 month postpartum check with a high viral load. So we need to remind ourselves about choosing appropriate birth control options for our patients postpartum. I don't have time to talk about that today, but I would encourage everybody to look into it if that's something that you're navigating. Moving into postpartum care, the recommendations are to consider a multidisciplinary approach. I think that goes without saying. As we navigated in our system was going with the lactation consultants to work through risk reduction tactics. And then some systems actually are recommending case management or social work considerations because of the challenges of having, mothers, HIV is being managed in this clinic. Babies, HIV is being managed in this clinic. Baby's pediatrician may be over here, or family doctor may be over here. Mother may be seeing OB over here. There's so many hands in the pot as far as who's managing what and who's the first person this patient's going to present to, with a breast or nipple complaint in the postpartum course. And so they wanted to recommend that that patient have a point person, so that way they could immediately kind of connect those groups to relay information as it came through. In that multidisciplinary approach, I understand that many of our listeners might be from more rural areas and may actually be managing their patients' HIV, outside of pregnancy, outside of the postpartum course as well. Even potentially with, a once yearly infectious disease consultation in a larger city or something like that. But what I learned from this case was that we needed to be really clear about who was following this patient's viral load. Because it gets muddy when, like I said, when you have so many hands in the pot. So we had set up this patient with a plan, and she's continued to be managed by infectious disease. Her child we're here in Kansas City, is managed by peds infectious disease at our local hospital. And when we're seeing her for postpartum visits, anytime she has a concern, if we have to pull a viral load, that information is getting sent immediately to both of those services. And then whoever's following the viral load must be aware of the infant feeding plan, because that was one of the things that was noted. It was just a simple message sent to the chart in our situation where we notified infectious disease that the patient was going to be returning and breastfeeding. And so they have then taken over a lot of that education moving forward, which has been great. And then who's following the infant? Peds FM, Peds ID. If it's not the same person that's following the maternal viral load, then having methods of communication is important. Recommendations that they have for postpartum follow-up clinic is based off of prior HIV studies. They recommend paying attention to the EPDS. As that EPDS goes up, the rate of non-adherence to antiretroviral therapy goes up, and so the risks to infant would presumably be higher. And then viral load, they recommend attention to viral load at all points of contact. So even if I'm not managing this patient's HIV or the infant at that point in time, if a viral load comes back, or you notice that the patient is late for their follow-up, they're recommending that be examined and or considered drawn that day if that's something that you're able to do. They don't have a prescribed frequency of postpartum viral load follow-up, but the expert consensus is to do it about every 1 to 2 months. If there's a detectable viral load, they recommend immediately stopping or modifying the human milk plan. So stopping if you have preserved human milk in the fridge, freezer, deep freezer, then you would go back to milk that was from a prior time before you had a detectable viral load. And they do recommend consulting an expert in HIV and breastfeeding, which you can do through the CDC website or your local institutions, and consider post-exposure prophylaxis for the infant. So the mothers should be apprised of this information as they're choosing this route. Additional information on postpartum follow-up is going to need ongoing education on breast care. So this is where our LCs came in and were super helpful in our first couple cases that we navigated with this issue. They were able to emphasize the importance of reduction of overproduction because they had noticed increased transmission for overproduction secondary to milk stasis, not completely emptying the breast, early identification and presentation for sore or cracked nipples, mastitis early when it presents, and then thrush treatment is recommended, and recommended early for these babies, and potentially for mom as well. So moms were educated to come back or call the clinic that day that had presented. Additional information on postpartum follow-up. So these are obviously patients that we are not just seeing for a 2 and 6 week postpartum visit, but that we would be seeing throughout the year, or someone would need to be seeing throughout the course of the year or two after delivery. Rapid weaning was associated with higher rates of viral shedding in human milk in the pre-antiretroviral therapy era. So as of right now, we don't have studies in the antiretroviral therapy as far as rapid weaning, but they do recommend considering a slower wean over the course of a few weeks to reduce the risk of transmission. The bottom line on stopping or modifying human milk situations is in maternal detectable viral load is present, mastitis, and bleeding nipples. So if any of these come to pass, then the mother needs to stop breastfeeding until the breast tissue is either recovered or the viral load is back to being sustained and negative or negative. Stopping human milk or modifying human milk options. Some of these are fairly obvious, but as I mentioned before, you can provide express human milk from a viral load suppressed period. There is something called pumping and flash heating. This makes me a little nervous, but apparently it's studied, so I'll come to that on the next slide. There is an option to provide replacement with feeding formula or donor milk, or you can choose to permanently quit providing human milk. All four are options. So flash heating, what is it? It is documented to eliminate HIV from human milk, and essentially is putting a sample of milk in a glass container within a pot of water, boil the water, and immediately remove the milk when the water is boiled. It's cooled to room temperature and serve. I was a little shocked to see that this was included in the information, but I suppose that this has been tested and is readily available online as an option if the viral load becomes detectable. Newborn and well child care. I feel like this is probably where most of the discussion, most of the questions from mothers so far in my experience, my large sample size of 3 so far, have had quite a few questions. So in the perinatal period, this is similar to what we've been doing for years, not necessarily related to breastfeeding, but we will do the virologic-based testing at time of delivery for HIV RNA or DNA NATs. I put in this little reminder at the bottom that there's specifics when it comes to maternal non-B subtype or group O infections. If we know that information, the testing is a little bit different. They need a dual target DNA RNA testing for infant. Based off of that information at delivery, it helps us determine whether there's a high risk, medium risk, low risk as far as viral transmission is concerned, and then what antiretroviral post-exposure prophylaxis should the babies be put on. So if anything's detected and positive, then that's not the patients that we're talking about. We're talking about human milk for babies with birthing persons with undetectable viral load. This slide here refers to the routine screening HIV exclusion criteria. So a baby who's not getting expressed breast milk or direct human milk feeds, we would be checking for their HIV risk, screening for their seropositivity at somewhere in that first month of life, 1 to 2 months of life, and then 4 to 6 months of life. In very high-risk infants, they recommend at birth and then 2 to 6 weeks after antiretroviral drug discontinuation. I'm not going into detail about this information because that's a different lecture. Also available on the CDC website. So here you can see 1, 2, 3, 3 tests that would generally be performed on the infant in that first year. And if they were higher risk, which shouldn't apply to our infants receiving human milk, the testing number should be about 3 for that baby, compared to the human milk fed infant screening recommendations, which are at birth, 14 to 21 days, 1 to 2 months, and then every 3 months while receiving human milk, 4 to 6 weeks after cessation of receiving human milk, 3 months and 6 months. So it's what, 5, 8 at baseline, plus every 3 months in that time frame. So it's a lot more blood draws and sticks for this infant compared to the non-human milk fed infant. If there's ever a positive test in an infant, you would immediately repeat for confirmatory testing and allow the mother to continue to provide breast milk, because obviously there's concern that the infant has already been exposed. I'm going to skip this slide because this is talking about perinatal exposure, infant antiretroviral prophylaxis during provision of human milk. There, as I alluded to earlier, is no consensus on this plan. They recommend 6 weeks of nevirapine if the parent is on antiretroviral therapy in resource limited areas. So at baseline, that is what they're recommending at this time. But again, as I referenced earlier, the infants who were exposed to breast milk without being on antiretroviral prophylaxis, if they did get HIV, they did have a higher rate of drug resistance. So there are several expert opinions that support infants being on persistent antiretroviral prophylaxis, but doing 6 weeks or 6 months and then discontinuing is also an option. I've included a couple trials that describe this a little bit further. There's a band trial that was done in Malawi with just shy of 700 dyads. In the arm with maternal antiretroviral therapy alone, the transmission rate was about 4%. For the infant that was on prophylaxis alone, the transmission rate was about 4%. Mother was not on antiretroviral therapy. And for controls where there was no therapies in use, the transmission was about 7%. This study also noted that there were no transmissions if the viral load is less than 100 copies per milliliter. And I could have mentioned this earlier. Our lab in particular uses 40 or 50 copies per milliliter as the undetectable viral load level. So 50 to 100 in our case would be detectable and would not be recommended for breastfeeding. Every lab's a little bit different, but most labs around the United States are using 40 or 50 cutoff. This trial did have a 48-week follow-up, so almost a complete year in determining the risks if the infant was on prophylaxis. The prophylaxis regimen options that the panel has generally agreed upon are 2 weeks of zidovudine. Everybody seemed to agree that that was reasonable. Optional regimens where there's disagreement about is zidovudine for 4 to 6 weeks, or nevirapine for the duration of breastfeeding. Unfortunately, nevirapine is only for kiddos that are greater than 32 weeks of gestation, but we know that it's hard to get breastfeeding successfully going for those early preterm kiddos. So I don't know how often it would be that we were providing an antiretroviral prophylaxis for a kiddo under 32 weeks. I'm not referring to the dosing schedules. That's a different lecture, so please see that if you have questions about it. In clarification of all of this, providing human milk continues to be considered not recommended for newborns that are at high risk of perinatal HIV acquisition. This includes those who were born to persons with a viral load that was not suppressed, someone who recently started antiretroviral therapy, or recently had an acute or primary infection not on therapy. If the newborn is at high risk and they are provided human milk, the panel is very clear that they recommend 6 weeks of presumptive HIV therapy, followed by daily nevirapine until 1 to 4 weeks after weaning. I did include this because the patient that I was taking care of did make it very clear that even if her viral load was detectable, she intended on breastfeeding her infants regardless. So we needed to be prepared for what are we going to do in that case if she presents with a detectable viral load. Thankfully, she was a sustained undetectable. Ethics considerations that I wanted to include in here is that so like earlier, the way I was thinking about, what are we telling families when we show them that if they can breastfeed safely, provide human milk safely, what are their likelihoods of closer social emotional connections with their infants? Similar questions to that, just things that came to me were the situation with partners. So with 2 adults who can consent, if the partner's viral load is chronically suppressed, we consider the apartment treatment with PrEP as optional. So an adult in this situation can consent and say, my partner has been virally suppressed for, as long as I've known them. I'm going to stop taking PrEP. I don't want the side effects of this medication. I trust my partner to continue their antiretroviral therapy, whatever it may be. And we can accept that. there is a weird nuance to accepting that from a newborn who cannot consent to that. I feel like that's one of the things that in discussion as we were reviewing this, that people were feeling that was hard to accept this change because of the newborn's inability to consent to the risk of having a lifelong condition. Something to think about. And then another thing to think about for me was that the risk of transmission and if the viral load is suppressed for patients that are providing their expressed breast milk, expressed human milk, or direct breastfeeding is similar to the risks of transmission of HIV during their pregnancy and during their labor. So for me, I was trying to wrap my mind around the thought of, if I have someone who's been working very hard with their ID physician to control the viral load, suppress it, remain as healthy as they can be to prepare for a pregnancy, if I trust this person, has been, this is a wanted pregnancy, they've been working through this process to manage that viral load cautiously, carefully through pregnancy, labor, why does my trust suddenly fall off in the postpartum course? And so I tried to use this to kind of frame some of my thoughts about it. As I was learning about this and making these plans for this particular patient. And so I just thought I would include it as something for others to consider and think about how they feel about that kind of transition through the pregnancy lifetime. I did want to include information on the National Resource Hotline. This was an excellent resource. I called them. They were fabulous in helping me prepare for this patient and educating me on things and leading me to resources. So if you ever have a patient case situation where you're needing resources, I would 100% recommend reaching out to them for their services. I've included resources as attached at the end, including the CDC information. And then we get to open it up for a few minutes of questions if you have any.
So Dr. Friedland put in the chat, is there any marginal benefit to expressed human milk over actual breastfeeding? If the answer is no, does that change if there is nipple fissuring with no detectable viral load? Is blood as safe as breast milk? And then he said, methinks you answered this. So
I did not see any particular studies that were done on birthing persons who chose to direct breastfeed exclusively compared to birthing persons who chose exclusive expressed human milk. So if one chooses pumping only versus direct breastfeeding, I haven't seen anything that shows if there's an increased or decreased risk, depending on either route that you go there. I don't know if that helps. I don't think I answered that question in the talk, but hopefully the rest was answered. Does that help? Okay.
Are you finding that insurances are covering all these additional viral load testings and HIV screenings for the babies and things along those lines?
I have not heard that they are not covering those. I did have a colleague of mine or a friend of mine who recently did rotate through at the with PEDS ID, and they've had I think they were saying somewhere around 20 patients over the past year and a half that have gone through, and based off the changes, the recommended changes, I don't think that they're having any issues if they're documenting that they're breastfeeding or providing express breast milk. But I haven't heard about any particular companies in general, if there's one over another that's causing any issues. And unfortunately for me, I have not ordered the viral load on an infant myself, because my infants so far because I live so close to Children's Mercy, have been going to Children's Mercy, which I don't think is bad. We're still kind of early in figuring this out locally. So, but maybe in the future, I want to be prepared to take care of these kiddos if we need to.
My other question is regarding the flash eating of breast milk, which just makes me cringe as someone who previously breastfed. I know they tested the milk for not having HIV, but was there anything in there about is the benefit of the breast milk still there after you presumably heat it to the point of maybe denaturing proteins or things like that?
Yeah, no, I did not see any information about that, but I also had some of the same questions. I remember, just reading about various things with breast milk, and also had the concern about denaturing proteins. But no, I don't think they included any information about the nutritional status of the milk after flash eating. I do think that that's probably why that they have you, one of the reasons that they have you remove it right after boiling, so that it's not at a sustained boiling point.
Interesting. Thanks.
Yeah.
So did you think, what is the reason for the increased risk with somebody who has planned combined feedings? Because it's not like it's just happening willy-nilly. They planned it. So you would think that
Yeah.
they would still stay on their antiretroviral therapy. So what's that
Right.
about?
So that is thought to be twofold. So the one that's a little bit more like evidence-based information is that those who choose to do planned feedings are more likely to skip a pumping session and have that milk stasis issue, where if they do a formula feed, they might have milk that's not expressed or emptied from the breast as frequently as someone who's doing exclusive breastfeeding. The second, the one that's a little bit less evidence-based, but has like there are several groups that talk about this. I just can't find the level of research and data that makes me feel like this is a real thing. But they are concerned about what's called what they're referring to as kind of like a leaky gut. For some reason, there's this theory that formula causes the enterocytes to be able to be more permeable, essentially, and that potentially the risk of the viral absorption would be higher if you're getting both formula and breast milk. But again, that one I can't find enough evidence that I feel like it's real just yet, but you will see that in literature and as information that's included for why they don't recommend planned combined feedings.
Thank you.
Yep. I think is that a wrap for tonight? On questions?
I think I don't see any more in the chat, so I
Yeah.
think thank you so much, so informative, and you've obviously done so much detailed research into this, so it's really helpful. Thank you.
Yep. I hope it helps at least someone be aware of the change and not surprised like I was when I first heard about it.